Hello, everyone, and welcome to the International Law Institute webinar on medical procurement to address COVID-19. My name is Kim Phan, and I'm the Executive Director of the International Law Institute. In recognizing the urgency of medical procurement in addressing COVID-19, we're offering this webinar today. And the Institute has developed an online course on medical procurement and supply chain management. This course will be delivered online July 13th through the 17th, and in person at our headquarters in Washington, D.C., October 19th through the 23rd. We have also developed a course on medical procurement, supply chain management, and contract administration to be delivered in person October 19th through the 30th. Let me say a word about online. We recognize that the best training experience is to be at ILI in person. But right now, it is not possible for us to be together. So if you register and pay for the tuition of an online course now, you will also be given a scholarship of equal value for you to come back later to attend an ILI training program. And you will have up to 3 years to utilize the scholarship. You can find a list of our course offerings at www.ili.org. Thank you for being here with us, and I hope to welcome you to the International Law Institute in the future. Let me introduce you to the course advisors and also the speakers for today's program. Alan Rotman is a consultant for the USAID Global Health Supply Chain Program. And Alan also worked as a procurement specialist for the World Bank, the African Development Bank, and the Millennium Challenge Corporation. And Valko Sokorica is a faculty at ILI, but he also serves as faculty for the University of Belgrade and the University of Rome. And in addition to that, Valko has had decades of experience working on emergency procurements, everything from hurricanes to floods to medical crisis. And Valko has also worked at the Inter-American Development Bank, the European Bank for Reconstruction and Development, and the United Nations Development Program. So welcome, and I hand this over to you, Alan. Alan?
Good morning. Good morning, everybody. Next slide. We have a long series, not too long, but interesting set of slides this morning to take you through the COVID experience from a procurement point of view. This is really part of medical procurement, and it also goes into health procurement. And we're going to show you what is the response to the crisis that we've seen so far in terms of procurement, how the markets have been really very dysfunctional. And we know that the markets have been disrupted, and we'll go into that as well. All this leads to a risky way of doing procurement, something new to people who are working into the field, the health specialists, the pharmacists, and even our financial specialists who have to pay for procurements in advance, which is not the normal procedure. And before we end, we want to talk about what's next, how we talk about the recovery period, how we talk about predicting what is the best way to plan for the future, and we'll end up with lessons learned and be able to take a lot of questions. You'll also be able to type in questions on the chat line as we go along. We're going to be collecting a few. Kim, who is moderating, will collect a few questions and will interrupt us now and again when we get a series of questions that will guide us a little bit further in our webinar this morning. Next slide, please. First, we want to talk about what is medical and health procurement, and we want to show you the full range of what is going on. Next slide. Really, in medical and health procurement, there's a wide range of players. We have so many people procuring that it's not necessarily well coordinated, even during normal times. There are many sources of financing, and the first player in all of these procurements is the government side. The government has hospitals which act as separate sources of procuring entities. They have clinics, they have central medical stores. And in many countries, the NGOs and the faith-based organizations provide up to 30% of the flow of procurements, especially with pharmaceuticals and medical equipment. And international donors also play a huge role United Nations Family Planning Agency, the Global Fund, Gavi, USAID. These are huge global operations, would operate in almost all our countries that we work in. So what is being procured? It's also a wide range of goods and services and construction work. Pharmaceuticals is the first thing that comes to mind. And in pharmaceuticals, there's a wide variety. There's essential medicines, which are your very ordinary antibiotics, paracetamol, over-the-counter medicines. You have specialized groups of pharmaceuticals for HIV/AIDS, for malaria, contraceptives for family planning, maternal and child health care, vaccines, cancer treatment. Most countries have a budget process where they divide up the health goods into about 10 categories. The other categories that money is spent on are long-lasting insect nets. In other words, people call them mosquito nets, LLINs, lab equipment, medical supplies, and medical supplies include bandages, intravenous equipment, saline solutions, a lot of items that you would not normally consider to be essential, but they are essential. And of course, clinics need to be rehabilitated. There's warehouses, which in the supply chain part of the business are a very strong focus of concern, because you need to have enough warehouse space to store and to distribute all the pharmaceuticals and equipment. And the last category is services. Healthcare is a people-intensive business, not only from the patient side, but also from the care side. And we have a third dimension, which is not really thought of all that often. It's the supply chain side. And this is the supply chain that stretches all the way from India and China through transiting either by airplane or boat to the port or to the airport of a country, and then distributing all the products down to the very last mile to the health facility level. So 3PL distribution, which is third-party logistics. These are companies that do truck distribution. Even now we have some drones which are being used in some countries. There's regular consulting services, subject matter experts, a lot of IT, logistics systems. Most of us have been through the experience of shopping on Amazon and other countries, other systems. The same type of backbone of information, knowing what's in stock and what is not in stock and when to reorder, exists in the supply chain for medical and health procurement. So IT has become a strong service which really has to be subcontracted out. Next slide. As I was saying, where is it being procured? We now live in a global supply chain. Most pharmaceuticals are made in India and China, and some specialized, a lot of contraceptives are produced in Thailand. Some countries have local production, but it isn't the majority of the supply. Pakistan has a lot, for as an example, has a lot of local production, but they do have to do international procurement. How is it being procured? This is the most complicated part of our health and medical supply chain procurement. Any source of financing has its own procurement process. So governments use their own procurement procedures. Global Fund uses its own procedures. UN agencies use their own procedures. World Bank uses its own procedure. Asia Development Bank, who I know we have a lot of people listening today, also has its own procedures. So the procurement end of this long medical and health supply chain is very fragmented because of all the different sources of money, different ways of procuring, and variety of professionals who have been trained differently. When do you procure? You procure 6 to 18 months lead time. Under these COVID times, we started to react within a 2-month or 3-month slot. This is not enough time to do procurement in the normal way, and it's even very tight, almost impossible to meet under emergency procedures. So this is the general picture of health and medical procurement. Please, next slide. We're going to go through a little bit of what's going on now, how we're living through the crisis. Some countries it's begun to subside. I'm here in the Washington, D.C. area. We're still locked down. 100 kilometers north of us, they aren't locked down. 100 kilometers to the south, they aren't. So we're still living through it, and we're just going to show you what has been happening. Next slide. Sellers are in charge of the market. They dictate almost what they want. And it's not that we feel that we're being bossed around as procurement people by all the sellers in the market. It's that we want to understand what the situation is so that we can bring in suppliers who have a good track record. We want to see good documentation from sellers. Some of them have full documentation, some of them don't. We're in the area of trying to be comfortable that we can work with a supplier and understand and go back to him several times with questions. But all of them are telling us, we are not delivery people. We can take it to the plane and we can take it to the airport, but we can't guarantee that the airplane is going to arrive on time. We can fill it up, we can stagger our deliveries, but we will even include in our contracts delivery, but we can't guarantee 100% delivery on the day that you want it. So we really have to build in a lot of backup planning and backup stock. And on top of that, sellers say, I'm sorry, I can't do business with you. We need my payment up front. I need the cash. I cannot pay for my raw supplies. I can't pay for my next person up the supply chain unless I have cash. And so we're seeing requests for 100% advance payment is the general rule. And sometimes we feel very lucky if we can find a supplier who will accept 50% upfront and 50% on arrival. The next slide, please. What are we buying? We're buying so many different types of goods. You've all heard about PPE, personal protection equipment. These are masks, KN95s, K95 masks, gloves, gowns, shoe covers. I regularly see my mother who's in hospital, and I see what's going on in the hospitals. I'm not a hospital person, but they come dressed just like an astronaut with face shields, masks, gloves, gowns. They're completely, I mean, it's really an intensive intensive care situation that everybody needs personal protection equipment and several changes per day. Lab supplies, testing for COVID, now testing for antibodies. You've heard about the swabs, which are in short supply. These are the pharyngeal swabs, which are long enough to reach. My friends who have gone through the test, I haven't gone through the test, say that you don't know how deep it is. It's not a pleasant experience. And these are specialized swabs that were in short supply, but we're seeing them coming back now. I'm working with Haiti for the past 4 weeks, and we're preparing all this long list of equipment. They're in Haiti. There's not a steady supply of replacement of oxygen tanks. So the request has been for oxygen concentrators, small tanks that you can wear, like the firemen wear, with a mask to be able to help COVID patients who are in distress before you can bring them to a hospital. Portable digital x-rays, autoclaves, disinfection of PPEs is good if you have a very strong system. In Haiti, we're not really sure that there is time and good quality control on the preparing. PPE equipment normally calls for a spray of alcohol before it's washed and then washing. And then the normal intensive care unit equipment, emergency room. And I'm giving you the examples of Haiti, and you'll see if it helps you out in your own countries. The hospital system does not have enough beds. They have maybe 400 beds in the hospital system, and we're using 3,000 cases. 3,000 cases, meaning that a lot of them will end up in hospital, and predicting that this is why the quantities are so high. The curve is still going up in Haiti. Next slide, please. We really wish that people in advance could have everything ready so that we don't have to increase hospital space and bed space. So that number is a daunting number. 3,000 beds is, you might have been following the news, but the Javits Center in New York, when they turned this huge, and it's about 7 blocks long, this facility usually used for conferences, they put 3,000 beds in that facility. So you can think I know there's been a survey of public sites, hotel conference rooms and other areas, gyms, gymnasiums, even stadiums where these temporary sites can go up as needed. So tents and prefabs are not out of the question. It's being considered. It happens in other disasters as well, so the equipment is available. Next slide. We have many services that are needed during a relief operation. The best people who are prepared for that are not the banks and not the health facilities themselves or the hospital. The UN agencies have a lot of experience. WHO, PAHO in South America is the prime agency who we're relying on to help with on-the-ground evaluation. UNICEF, UNOPS, World Food Organization, all these are agencies that are used to handling disasters and emergency relief. And they're very good at training surge teams in countries, identifying case, keeping track of statistics. They will give technical assistance to the national laboratory where all the testing takes place. In Haiti, we have the CDC is overseeing the operations of the national laboratory, and so they're providing a lot of technical assistance. And it's really been helpful. We speak to them before we buy equipment. We get evaluations of our test equipment, the testing work, so they can also help out, as well as the UN agencies. Risk, you need to keep everybody on the same page. So risk communication specialists are another part of the manpower that's needed. And all the way down to the site level, people have to be trained and in the loop. And we know that there are teams out helping sites become ready as this curve is going up in Haiti. And next slide. Dysfunctional markets. So what are we doing? We have this long list of equipment, this long list of goods, services. Next slide, please. How are we going to manage this? So we're looking at the 3 variables, which are time, quality, and cost. The traditional trade-off has to be taken into consideration. Sometimes you can get goods which can come immediately, but the quality isn't good and the cost is high. Or sometimes you can get excellent quality, but the cost is high and the time is too long. And sometimes the cost is very low and then you wonder, is it really quality and will it arrive in time? So it's not business as usual, and we're using a simplified procurement approach. The World Bank on its public website, when you go to the section where you see the procurement documents, has now put out a set of simplified procurement documents. These are goods and works. And there's you can go through them. I've been using them. They've been very helpful. The internal processing has also been very helpful because everything has been post-review. So anything that we're doing is not being held up by procurement approvals, but we have to use our professional judgment, and we're working in the fastest way possible, which are quotations or direct contracting, also called sole source. The procurement approach consists of, you can send out and request quotations. There's a quotation sheet for goods, also for works. And most of the time, we don't really get the information needed when we ask for a quotation. So we're using emails, fax, WhatsApp, Zoom meetings, many times a day, back and forth. and we eventually end up with a full set of information to be able to see which one of the quotation, you can call them bidders, but they're not going through a formal bidding process, which one seems to be the best fit. The best fit is the idea behind value for money. So we really had to jump aboard the new procurement approach. The guidance from the World Bank, and I'm saying this because it gives you comfort to know that there's no bid security from the bidder's side, no performance security, no letters of credit. Next slide. So how do you know that you're going to be able to get what you asked for and what was agreed during the quotation stage? And you do go through a simplified writing of a contract which is simplified based upon the normal World Bank, and it's quite similar in many countries, goods contract. It's very simplified, lots of room for rewriting, no special conditions. How do you know that you are going to get what you want? You do know that you're writing into the contract an advance payment, like I was saying earlier, 50% or 100%. The guidance is that ideally you should be asking for a guarantee from a commercial bank. If it's an extremely large contract, several millions of dollars, it's worth the wait and the push to order to have a guarantee from a commercial bank. The standard way of doing business is a letter of credit. A letter of credit goes through the bank. Money is deposited with the bank, and the bank, this is a commercial bank, will write the letter of credit for 90% of the value of the goods. It's normally 10% advance and 90% on the letter of credit, and maybe it can be 80% on the letter of credit and 10% on arrival. But without the letter of credit, most banks are not used to giving a guarantee for goods. It's considered to be too short. They want to see collateral. And so on our last procurement, we came out with an alternative way of handling the upfront payment. What we did was we divided, and it was possible to have the goods arrive in a staggered fashion. So we actually had about 20% upfront for the first delivery so that we could see what we were getting, prove the reliability of the supplier. We paid upfront for the 20%, and then we had 2 more deliveries, each at 40% and 40% of the quantity. And so this allowed for some comfort. We paid 100% upfront, and because it was much easier to do it that way, to divide this into 3 deliveries, each one having 50% upfront and 50% on arrival, was too cumbersome and would probably lead to delays. So we decided to pay 100% upfront. Guidance is, please try to provide bonus payments for early deliveries. It's a good idea. I think each of you will have to decide how much a bonus it will be and work it out with your supplier. And Incoterms. We actually used an Incoterm from 2010. I'm showing you how flexible and how we've adapted, because the supplier was used to a 2010 Incoterm, which is DAP, delivery at airport terminal. So this is upon arrival at the airport, without going through customs, offloaded from the airplane, unloaded, and then the receiver, and we used PAHO or WHO as our receiver because it simplified the clearance of the procurement process. And they are actually the project manager within Haiti who's assisting the government. So these were all some of the details of a very practical, simple procurement approach, and we can come back to that later with questions. Next slide. Disruption in supply in the supply chain. I think at this point, are we on our slide for transition?
Thank you, Alan. And actually, there's a couple of questions that we have. So the first question, it's 2. The first question is, COVID-19 is treated as an emergency and quality of supplies is compromised always. Is it possible to ask derogation from donors, especially USAID and ECHO? So that's the first question. The second question is, the simplified procurement under this environment leaves the public sector unprotected. How to ensure this doesn't happen? And a third question came in from...
Whoa.
Sorry, go ahead and answer those first two, and then I've got a third question from Kevin.
All right, well, let me deal with the first one. So you're asking how to work with USAID. Most of you have USAID representatives working from the embassy. I've been working with the USAID project, and I know that we're in line for money. In other words, USAID wants to help with the COVID crisis. The full green light hasn't started yet, but there is money in the pipeline. And if you worked with USAID before, then you know that it's not a burden on the country to ask for this donor. They will take care of all of your procurement. They will take care of all of the delivery to the central warehouse or to the port or an inland place, if you want to name it. But there is the lead time involved. So even under ideal conditions, a 6-week wait is considered to be very normal when you put in a requisition or you put in a request after you have signed all the contracts and moved forward. So I think this answers part of the question. Kim, can you just give me a second question? I heard part of it, but I didn't hear all of it.
Sure. The second question actually comes from Emeka Eze, who is the Director General of the Bureau of Public Procurement from Nigeria. So his question is, the simplified procurement under this environment leaves the public sector unprotected. How to ensure this doesn't happen?
Good question. Good question. We chose the approach of asking around. And so we did ask about reputation of suppliers. We have new suppliers who have jumped into the market who we know haven't been in business of, in our case, of PPE, personal protection equipment, maybe since December. That would be considered an old supplier. Some of the newer ones we only see active since January. But then we have our other suppliers who have been in business for 30 years and have a track record with several clients, including WHO themselves or with the country. So I think that we're back to the very old way of a new normal. You have to trust your supplier. How do you trust your supplier? You should rely on reputation, being able to answer questions during bidding, be able to get comfortable, a relationship. This is very old school. I mean, we want to be able to see that the person, use Zoom at the other end of the screen, is comfortable asking questions and isn't going sideways on the questions. And I'll explain what I mean by sideways, because we've been asking for lab results from most of our suppliers. When we examine the certificate, does not have the information or the name of the company that we were expecting. And so we have to start digging into the supply chain of a supplier. Supplier can be a distributor, and then he can have a manufacturer in country who has a different name, and then there can be a third party, which is the importer into the country. So just keep asking questions until you get a sense that you understand where the weak point is and if there's a good answer on the phone. Kim, you were going to ask a third question.
Well, in the spirit of asking more questions, let me just go ahead and give you one from Kevin from the Asian Development Bank. He's in the procurement department there. And so Kevin's question is, given the volatility of the market, how are you undertaking price validation in advance of placing orders?
Price is not turning out to be all that much of an issue. We've been able to establish a range of prices, and the thing that is driving the prices is really the transport, not so much the cost of goods. The normal sort of rule of thumb for transport is to add on about 25% of the cost of the goods to reach their destination from China or India. Now the process is completely changed, and we're using the rule of thumb of adding 50%. So the cost of the goods is within a range. We've been able to establish the low and the high end. We usually compare with transport included. And so far, the prices, when they look very low, we end up asking a lot of questions. And we tend to see the price being reasonable or even at the low end, but the quality and the length of time in business for a supplier hasn't been so long. We turn to our country counterparts and ask, because we're working, the other flexibility to the bank is they're allowing staff at the bank to work, at least at the World Bank, to actually give technical assistance on procurement, help with evaluations and so on. So we've been tending to go towards the higher end of the price range because of the reliability and quality of delivery.
Okay, and we're going to save some of the questions towards the end to make sure that we have time. But let me just go ahead and just ask one more from the series, and then we can, wrap them up at the Q&A section. So as long as each source of funding has its own procurement procedures, would it be possible to go for global standards to serve for emergencies?
Well, having worked at USAID for about 3 years, I'm not sure that's going to happen. The UN system uses their own procedures. I must say, having worked in many different jurisdictions, shall we say, under different procurement procedures, I find everybody to be very professional and very careful and working to a high standard. So I'm not so worried about working under different procurement procedures, and I'd rather, especially in the emergency, that people be able to work with their own system and be comfortable with it, and be able to move quickly and make decisions in a flexible way. So it's I think what I'm actually seeing, though, is that each of the systems, the USAID uses a best value approach, which is value for money, essentially, where they're, and it's a negotiation process of going back and forth. And so this guidance that we've gotten from the World Bank is very similar to the best value method. So I think we're seeing sort of a kickstart towards a new world standard of how to do contracts in a very modern way, which is not to use least cost evaluation. So at least I am seeing that least cost evaluation is not what we're working towards in this emergency. The guidance actually that we've seen under the World Bank is the least cost technically acceptable. And since time is so critical, many of the bidders don't have the stock on hand or are too long in the production. So this really is helpful because time has become a factor in the emergency, and I think you should use that the best way you see fit.
Great, thank you, Alan. And Dalgo, we turn it over to you.
Thank you very much. Can we go to the next slide? I would like to piggyback on what Alan has said, and I would say in a lot of detail. And especially, I would like to highlight the fact that the healthcare systems were compromised big time. Now, I'm not talking about some type of healthcare system somewhere, but I believe with all their differences from, I don't know, Italy to Sweden to US, China, etc., they went under very stressful moments, and none of them was able to respond immediately to this emergency situation. Some struggled more, some less, but it was basically all the excuses were that this is an event that happens once in 100 years. And that's not really true, because events like this, emergency situations, we have every year. The main problem is inadequate planning. Inadequate planning, budgeting, funding, for emergency, whether it is a pandemic or is it earthquakes or is it flooding or fires or whatever. Here, in addition to the failure and the collapse of the healthcare systems, it was very indicative and typical to see a huge imbalance between supply and demand. On one side, we had the demand to skyrocket beyond this universe, and on the other side, we had the supply plummeting. The supply reliability was completely compromised. There was a constant drive to lower costs over years, I would say decades, and to create this efficiency of the least cost. But that in itself created a heavy reliance on global market sourcing, which resulted in serious supply viability challenges. We can also talk about another effect, which was dysfunctioning, or better to say, collapse of the global market. And here, I'm not only referring to the concept of geographic global market, but basically that market should resemble, in particular, when we talk about medical supplies and health, that it should resemble a stock-like portfolio. On the next slide, we can see that the critical shortages of key drugs and medical supplies and equipment, which Alan covered quite a bit in a lot of detail, so I'll try not to repeat what he said. But anything as simple as drugs, antibiotics, sedation, anesthetics, and so on, anti-malaria, all of these drugs were in short supply. It was difficult to find them. Then we can talk about the lack and deficiencies in the supply of raw materials, pharmaceutical ingredients, and the components. We can talk about also at length regarding the lack of availability of personal protection equipment, anything from rubber and surgical gloves all the way to the masks and so on. And I just want to mention also, like simple equipment which should be standard in all hospitals, and we should have sufficient capacity, like X-rays, we're in short supply. So we can, another very important thing is regarding the critical shortage of hospital capacity, how many patients they can take in. And then, of course, how much or what is the rhythm of taking in the patients. We heard all these weeks, almost 3 months now, that the doctors were talking, epidemiologists, that we have to flatten the curve. Flattening the curve, I guess, meant can we keep a control of the intake of patients into the hospitals because of the very critical shortage of hospital capacity. On the next slide, I would like to drive your attention to also a few other things. It's not only hospitals, rubber gloves and masks, etc., but also it is evident that we had a lack of control over manufacturing and shipping. Alan mentioned the issues with shipping, and also some of the countries and in parts of the world, in regions closer to home, there are or were manufacturing capacity which was compromised by not having either raw material or because these manufacturing has been put on hold or abandoned. Trade disruption, big time. Countries closed borders in order to protect national and local supplies. I even would like to mention a case between, I don't want to say the names, two countries where one of the countries, by mistake, I guess, a cargo came to their to land in their airport, and the customs, when they discovered that this is the kind of medical supply that they need, they practically put an embargo and did not let that cargo to go to their final destination. A lot of things happen. Lack of experts and consultants. People experts in pandemic response was critical, i.e. the need for more consulting and consultants in this area. Then it seems trivial, but it's not. There was identified a lack of IT capacity. Being locked and with closed borders, trying to get out there on the market and to see and find where are these supplies that eventually we might be able to get. People discovered and we could identify that the IT capacity was not up to the par, including things, simple things like, for example, web video cameras, because of course all schools around the world were closed and children had to go back and use the video cameras to be able to continue and watch their classes and continue their education. Last but not least is also the lack of financial capacity. You know, it was like there was a lot of cash that was missing out there for what the market insisted and demanded is a cash purchasing modality. So, you know, you could even, we heard stories that people had to travel somehow to different countries with bags full of money to pay for the equipment. Even that was not a guarantee that they will get the equipment that they were looking for. On the next slide, I would like to share with you a few ideas regarding how can we rebuild supply reliability. And on the next slide, we can see that in a nutshell, it is very important to, I would say, build or rebuild the relationship with suppliers, to get to know them better when the times are good. And this is, of course, something which we have to do and apply into the future. We have to support their businesses. Some are on the margin of being able to manufacture and produce and have their products available on the market at a different price. They cannot compete with the least price, but they can be a very reliable suppliers on our market. So this is something that we have to rebuild the relationship with suppliers, not just a transactional buy and sell opportunity. We, of course, have to use all these gadgets that we have, like, you know, WhatsApp, etc. Alan mentioned that, and then break the barriers in terms of using electronic instruments, including DocuSign and so on and so forth. I would like to pass it now to Alan to tell us about a little bit of how to avoid risks during COVID. Next slide, Alan, back to you.
Thank you, Veljko. So we're going to go on and talk a little bit about risks now. Please put some questions into the chat if you can, and we'll go on to the next slide. So how do you avoid risk? How do you avoid not getting your delivery in this very emergency nature that we're going through with COVID? Please, we find that technical quality is a good indicator of reliability of your supplier. If your supplier can give you all the technical information, the lab report, the certificates, the details on his cost breakdown, that would really be a really good indicator. The two main agencies that we use are the EU for the CE certification and FDA for also regulates in the United States. Now, next slide, please. Let me explain to you a little bit about FDA. FDA has a registration process where it asks for your name, address, name of company, and what products you're selling, because it wants to be able to keep track of complaints that might come from the public. A registration is not a full check on quality of the product that you're offering. So if you go to a supplier and he shows you an FDA registration certificate, that really doesn't tell you anything about the product. It just tells you that he's a recognized business and that he can bring products into the United States. Usually for the class 1, because FDA regulates under class 1, 2, and 3 risk levels. This is for medical devices. Pharmaceuticals are all considered very high risk and are brought up to the class 3 level. Under class 1 and 2, for such things as surgical masks and personal protection equipment, it's a low risk or moderate risk to the patient. This is not something that he's going to be ingesting, or an X-ray machine, or an item like that. And these devices, the simple medical devices that are low risk, do not get technical approval. There's something called a 510K pre-market technical report, and this has been waived for at least 70 class 1 products and some of the class 2 products. So if you are trying to rely on FDA, FDA is good for the very high risks and for the pharmaceuticals, and it does look at the good manufacturing practices, the same that WHO does for pharmaceuticals. They need a GMP certificate. FDA offers the same type of GMP certificate. But for a lot of the products that we're dealing with in the COVID time, we do not see approvals, formal approvals, because the products are low risk. I think I pass back to Veljko now, and please can you continue and explain a little more about the CE process?
Thank you, Alan. Well, in a nutshell, it's very similar. Here in these graphics, I just want to share with you how it is done, and let's say the limitations of what really this certificate means. It is driven by whoever has the medical device or whatever needs to be certified within the EU arena. So it starts with finding that particular directive, EU directive, which is applicable to whatever product or device we're talking about. And then we need to identify within that directive what are the requirements that that directive has for the product. Then it has to be demonstrated and shown which route to use in order to demonstrate conformity. Then once this is done, it passes the test and the assessment of the product's conformity through, I would say, a team of experts that are responsible to provide the conformity passing grade, and then it goes further to compile the technical documentation. So all of this is done by whoever has the product, has manufactured, and so on. And only after complying with all of this, they can receive the certificate and put the declaration and affix the CE mark. On the next slide.
Veljko, I just want to interrupt just for 1 second. We also see a lot of certificates from CE that just have started the process but haven't finished the process of CE certification. So you have to read what's being submitted carefully. Back to you, Veljko.
Thank you, Alan. Exactly. So I would like to add a few more issues regarding how to avoid the risk during the COVID. And definitely one of the most important things that comes to my mind is we need to mitigate the supply chain. And the fact that somehow we depended on this as a single source or one source. And I'm talking here about some, even in private sector, of course, sophisticated companies like Apple, etc., that rely heavily on the one source dependency and the chain supply. So it's a serious business. Of course, it becomes even more serious when we're talking about health and medical supplies. So I would say that here we can identify that the root of the causes in the commodity goods, in the generic drugs, which were driving the prices lower and lower. And basically, when we have products that are produced for pennies instead of dollars, then this creates an unbelievably efficient and narrow supply chain that have no redundancy and no resilience. And here a warning for all of us, I think, is that tackling the supply chain diversification is something which needs to be done by all of us, including healthcare organizations, insurances, etc., and also distributors, middlemen, everybody, because we have to move away from the cost-only consideration for evaluation and comparison, for which we have paid a huge price now in this crisis that we're experiencing. On the next slide, I would just like to suggest a few more mitigations that are required in order to deal with and to avoid the risk. One thing that we have to mitigate is the dependency on the global, dependency on the regional, and try to concentrate and move the productions as an alternative, or I would call it complementary, of certain items, starting from the most simple ones as personal protection equipment and testing supplies, etc., closer to home. We need to make sure that some examples, for example, regarding the North Italy, okay, and the availability of test kits, swabs, and so on, were in short supply, of course, because of what was happening in northern Italy. The lack of a nearby domestic production capacity, we have to somehow mitigate by looking for partnership. I think somebody today mentioned that there are companies from around the world in different countries that are willing to come closer to where the opportunities are and build partnership to produce domestically. And in addition to use, or I would say to complement the global supply chain. Of course, let's make no mistake, I'm not talking about replacing. We can not eliminate the big market. And of course, when we try to be self-sufficient, we have to take into account that ramping up supplies takes a lot of time. Another thing is we have to enhance our knowledge and transparency regarding the availability and where exactly we can find different health supplies and raw materials and ingredients that eventually we will need, or we can use, or we can import to produce in limited manner pharmaceutical, medications and other products. So, of course, Alan mentioned the lack of polypropylene, which is used in the production of respirators and N95 masks. It's another issue which can be resolved and has been a global issue so far. On the next slide, I would like to, in the following slide, I would like to share with you our approach, which we try to coin regarding, rather than what type of immediate solutions we have right now. We don't have the recipe, we don't have the silver bullet, but we do have the possibility to think, how can we do things better? And I believe it goes all the way from identifying the right strategy, and also it relies in strategic planning. And in particular, I think that it's going to be very important to invest in finding in data mining as well as artificial intelligence. And there is a huge leverage capability that we can have in putting that together with the technology, which may help not to prevent, but what we like to say, predict, identify shortages of other manifestations that are coming, that will come. For example, disruptions in the market because there is a spike in large orders and so on, can be some kind of signals around the world for us to rearrange or readapt or retool our supply and buying strategy. So preventing is the key word here. We have, with significant investment in the data mining and artificial intelligence capabilities, we can create comprehensive business intelligence in real time, and this is the key word, necessary and critical. We can also respond to challenges using these predictive models. We can build risk mitigation plans and models, and we can have them updated thanks to this type of technology and approach. And of course, we need to be ready for the second wave, whether it is going to be COVID or something else. But these things will help going to continue to happen in the future. It's just a question of when and how much, and we have to invest today to be ready for this type of events. On the next slide, I would like to share the following slide. A few lessons learned. Some of them I will recap and repeat. So the first one we discussed at length, and it's about the health supply chain system compromised. And here we have identified, and in this session today, we tried to highlight the importance of merging somehow the medical skills and the procurement skills, and to make sure that we don't leave all the weight of this pandemic type of thing on the shoulders of doctors, but also that we get professional procurement experts to assist and help and in with the logistics and so on. And as I said, especially in the preparation and for these events into the future. That, of course, entails planning for appropriate budgeting and funding, and disregard or put aside the concept of once in 100 years. Of course, as we go and within ELI, we are going to mature and develop using the skills of different economists to make sure that we can simulate and somehow indicate and see what is the price that we are willing to pay. Are we going to pay it up front, or we are going to push it back into the future when these things happen and we're not ready? Again, repeating, not only for this type of diseases or pandemic, but we have to think and be ready for other massive disruptions. I just remember a few years ago, there was this volcano in Iceland that practically blocked the whole traffic, air traffic in Europe. I was at that time working in London, and it really felt very similar, I would say, like the situation today, only that it was somehow reduced or a ring fence to Europe. Now, again, what are the lessons learned? Do we think that the sourcing strategy will become resilient? Will companies actually change their sourcing? Well, I don't know. I mean, there are some indications. Of course, the first reactions, we have to do that. But PricewaterhouseCoopers did a survey just recently, and we can see that still about 1/3 of those that were surveyed said that the supply chain issues are one of the top priorities of their concern, but however, that the cost criteria is still their top priority. Finally, I would like on the next slide to give you a few tips, starting as I like to highlight from long-term to short-term, rather than only concentrating on today and now. And from the long-term to short-term, as I mentioned, I think it's important to develop strategic planning, to look and develop market studies and analysis, and I highlight the word comprehensive. So we need to use all the tools and the knowledge that we have from different aspects, including health, economy, technical skills, IT, and so on, to make these studies and analysis. I would also like to highlight the importance of cost studies and sensitivity analysis. A lot of questions that we have received really go into this area. Like, how much are we paying? Are we paying too much? How can we do this direct purchasing? Alan mentioned the different ingredients. Sometimes the cost of the product is not that high. However, on the other side, the cost of transportation and other barriers really add to the cost to rocket high. So another thing which is very important is we have to develop from long to short term the concept of fit for purpose. And here I would say globally, regionally, countries, municipalities, and so on and so forth. In the United States, we could see that with this pandemic, we discovered that indeed there are about 50 states in that country, that each one has, in parentheses, also some of their selfish interests, of course, their responsibility to defend and to reply to their own taxpayers. And all in all, we even when it seems that it was compromised, but we have to make sure that we understand and build the concept of value for money, including the agents of pandemic situations like the one that we have. And moving to the next slide, and speaking, I would say, in a rather more colloquial and simple language, I want to share with you what are some of the tips and then some of the thoughts that together Al and I had. And it's like how to satisfy this emergency and maintain integrity, anti-corruption and behavior and standards. It's very important. It's very important. We cannot just accept, quote unquote, the rule of the jungle. We have to think about the consequences. You know, political decisions, professional decisions, all sorts of decisions. There is, you know, some people think about, well, are we all on the same boat? Well, not really. We are all in the same store, and each one of us has different boats. Some are going to navigate easily or better. Others are going to navigate with a huge pain. And then the consequences of our actions today definitely are going to affect a lot of lives, not to mention how many people were laid off, etc., etc. Then we are really facing like the very short, immediate, into our face question that we need to buy products to save lives. Indeed, but the crude reality is that the market became predatory, and I don't think that there is another better word to explain it. It's indeed, it became predatory. As I mentioned, there was a jungle out there. Prices, delivery times, quality, compromise, all of that would change from an hour to another hour. Some contracts, which were pacted even before COVID, of delivery, they were just put off because somebody else was paying a higher price. And they would say, no, we're not in breach of the contract, we'll deliver it in 3 weeks' time or 3 months' time. And then the question is, okay, since everybody's paying more, sure, I can pay more, or I should pay more. I have to protect the lives of my citizens or whatever, but how much more? And that is something which, with the cost studies, etc., in the future, we should have an educated answer to understand what is the sensitivity, how much more, and again, the comfort or lesser risk to pay more when we're dealing with reputable companies, reputable suppliers. But we need to know them. We need to develop our knowledge, skills, as well as I said, predictive methods to say who is reputable and who is not. Again, Alan mentioned a couple of times the issue about payment, and we did receive also some questions along those lines. And it says that, well, a lot of them were asking a payment upfront, 100%. But of course, what is the answer about security? What happens with the security? Are we going to get it? And so on. And it was almost like difficult to ask any questions or put some, let's say, counterbalance conditions for the 100% payment. Again, what other choices do we have? And I highlighted in the previous slides the fact that we need to collaborate and even enhance our collaboration with suppliers. But in this critical situation, it was the first to fail. So we can do it, we can do better, but we have to be ready that not necessarily that's going to be the guarantee for mitigating any similar situation in the future. Finally, we have to be flexible, we have to listen, we have to adapt to the situations, and we have to accept the reasonable challenges. Alan, I would invite you to say a few words more of, if I forgot something of what we discussed, and to move to the next slide.
So just to follow up on Veljko, I have two main points that I think come in the summary. One is that procurement and supply management, which normally are considered to be the warehouse people, the truck drivers, the ones who you don't have to worry about, it's not an important function, all of a sudden have become the number one issue that's on everybody's lips. Here in the United States, the governors and the high-level politicians and everybody has become a supply chain and a procurement expert. They know whether or not they're getting their goods on time, how much they're paying, whether it's good quality, and so on. So I feel quite honored that we should all be joining the ranks of the higher level people. And so we should take advantage of this. What is going to be the new normal? The new normal is that this is going to become a highly professionalized profession where judgment will count and that there will be expectation of good reliability and reputation. We have to move into the modern era of being able to fit for purpose and being able to do the trade-off between cost, time, and quality. So the 2 points are, it's been elevated. It's now become a real profession, especially health procurement, which is now going to be the exact twin counterpart of the actual health service provider, the doctors and nurses and so on. And secondly, that this has to be managed in a more professional way. Least cost? No, least cost is not the way to manage this going into the future. Coming back to today, how are we going to finish off getting through this COVID crisis? We're just going to be solving problems one at a time and moving through and solving them as we go through. We're going to be able to manage the ongoing situation. We're not going to get to the ultimate perfection of being able to have the perfect purchase where we get the best quality, the best timing, and the best delivery. So we'll just manage these as we go through. I hope this has helped you all and that we will continue along the journey to better days in the future. Thanks so much.
Oh, thank you. Thank you, Alan, for a very informative and urgent and relevant presentation right now. We have several questions, and I'm just going to say some of the questions were answered along the way. And for those, just in the interest of time, if we don't answer your question live in this webinar, we're going to leave your questions open for Alan and Veljko to answer, either writing you after this, but feel free to email us if you do not feel that your question was fully answered. So I'm going to have a compounded question. One is, countries with low manufacturing capacity appear to be very exposed to all of the risk. What do you feel should be their strategy against this risk? And that is one question from Africa. And I'm going to compound it with a question from the Middle East, which is, you had mentioned about the need for oxygen concentrators as alternatives on oxygen containers. Would it be possible for all NGOs working with vocational training to train local people to make these concentrators, bearing in mind that less developed countries have their ports closed and it is difficult to import?
Maybe I can take a try at it, and Veljko, you can come in, or the strategy of how to take advantage of your manufacturing capacity. I think this is an opportunity to plan for the future, but I'm not quite sure that during these next few months that it's really easy to set up manufacturing. I can give you that we have been looking for local manufacturers in Haiti, and we did find one that is manufacturing in their free trade zone. We asked, and they have, and this is actually a Taiwanese company that set up manufacturing in Haiti to export for the US as prior to Haiti. what happens is that you rely upon an import of raw materials, and polypropylene is what they needed to import, and there's a worldwide shortage of polypropylene. And for them to move up to the quantity that we needed wasn't easy. So there are small quantities, and I'm saying 10,000 masks, 20,000 masks, 30,000 masks, and our request was for 100 or 150,000 masks. And so, yes, I think you should start. We know that we've had a success in identifying face shields, the plastic shield, clear shield that you wear to protect your breath from going out. Even if you're wearing a mask, the most standard practice is to wear a face shield on top of the mask. So that was available in Haiti, and we're supplying locally. So cloth masks, yes, we're not buying masks for the general population. Cloth masks are being produced locally and being marketed locally. So I would say that manufacturing pharmaceuticals, no, maybe importing and later and doing repackaging, yes, but it's during this time very hard to come up with good quality control in large quantity. On oxygen concentrators, I'm sorry, I don't really know what it takes to manufacture oxygen concentrator, but I suspect it's the same idea. It's that the raw materials and the need to be imported, and assembly can be done, but I don't know about starting production from scratch.
Yes, if I just may add a few things. I mean, we definitely will not be able to locally resolve, and then I did not, and I guess from this question, it's obvious it's not like every country can do everything themselves, but I believe that some kind of regrouping regionally, making this manufacturing capacity available closer to home is also very important, and the countries then, rather than to starting from scratch, they maybe should support within the regional, and I'm sure there are some treaties and so on in different continents that can be the facilitators to identify some, and of course, this is not today for today, it's impossible, it's very difficult. But what can be done, we were talking about disinfectants, we were talking about sanitation, we were talking about masks, this, that, and the other, and as Alan was saying, the plastic shields. A lot of those things can be done and can be available, for production locally. For example, we have seen scores of pictures, disturbing pictures, and I don't want to mention any country in particular, but even from the big USA, from certain hospitals where you had medical teams without the proper or adequate or sufficient supplies of protection, clothing and so on and so forth. So a lot of these things, I believe, can be done in the future. So planning for that is important. I mean, we should not all just buy tomatoes from one country. We should be able to grow them locally. The same thing here. I think there should be a limited, even if the cost is higher, but as I said, capacity that needs to be thought about for situations. Two, one, when the price of these products of the international markets goes up, so that it makes sense for them to produce locally, but also on the other side to say for emergency situations. Also, I would say it is going to be important to invest in higher capacity of storage. There's no, we will simply have to invest. It's common sense, of course. We're good economists, and I'm sure we will talk about this in our in-presence course later this year, hopefully in October, and we will try to take some cases, some good cases, and elaborate this further. But I think that there is opportunity. I would say we need to open the door rather than to say we don't have the capacity.
Okay, and let me go ahead and group a couple of procurement questions together for you.
Sure.
So, how do you address the fresh supplier in this emergency situation under direct procurement process? And how do you evaluate the quotations received? Do you set up quality cost experience ratios? And how would time be an evaluation factor using least cost evaluation? And why does it take 6 to 18 months to procure?
What was the second question, Kim? I didn't hear the second very well. The first one is about direct contracting. The last one is about evaluation factors. What was the middle one?
Okay, so the middle question was about how do you evaluate the quotations received? Do you set up quality cost experience ratios?
Quality experience. Okay,
So,
go first.
maybe I'll just jump in and sort of make a general comment, and then we'll work through each of the questions. The price seems to be the last thing that my team is interested in when we're evaluating suppliers or looking at quality cost ratios or time. Most people, the cost is not balanced out in a sort of direct quantitative way against all the other factors. So it's much more about who is an acceptable supplier overall, and then do we enter into negotiations with them. So where do we start with our top negotiating, and then we would move to this next one. So I'm just explaining the process has not been extremely structured, and that's why we're calling it direct award, because to do a full evaluation where you have the same criteria for all the suppliers is not the way it's really turning out. We tried to do that, but it didn't really work out. We could request written quotations, but more we're getting faxes and emails without all the quality information. So people start with price, and then we work our time into transport time and into quality. So it's not a straightforward evaluation or bidding process. It's much more of a negotiation process where we negotiate with each of them in order to be able to get the information we need about time, if it's acceptable time or not acceptable time. We don't want to spend weeks in evaluation, but rather want to spend days in evaluation. So we go for what is readily available. Just to give you a little background, in the Haiti situation, there is a long-term contract that will be available towards the end of June, maybe beginning of July, but it took this long-term contract was a bank-wide contract, framework contract with one supplier to supply many countries. It's taken, it's been signed, and delivery will start sometime in June. So from the beginning of the COVID crisis to now, that long-term contract that's how long it took. So that explains a little bit of the 6 months. Even under emergency conditions, that very important contract has been taking 6 months from the time of initiation to the time of delivery. Just about, maybe 5 months, maybe 4.5, but that's a complicated one. We're trying to fill the gap in our procurements to have very short-term product arrive quickly. I'm sort of grouping the answer here to try and answer all the points.
If I may add just a few words to that. If we're talking about from now on, we can provide a different answer. Very much it goes in line with what Alan was saying. But I think that especially when we have these emergency situations, we need to have good, solid teams of experts in the area. If it is medicine and health, then doctors and pharmacists and so on. If it is IT, then we have to have IT. But on the other side, we need to have people that are specialized in procurement, people that do this every day and that they are absolutely, how should I say, confident in their knowledge and have the capacity to answer these particular questions for each country, each situation, institution. I would say that is very important. So investing in building the capacity of experts in procurement is definitely one of the things that I'm sure ILI has been working all these years, but also is something that is even more important for the future. And that's your, that's your best insurance, I think, and that's the best answer to the question, because it might be, fit for purpose, a solution in one country, depending on so many characteristics, including political system orientation, philosophy, etc., might be different from another one. Definitely, it comes with, I like to compare, it's like having a good solid pilot in a big airplane in the cockpit. And he's the one that leads these processes, and he knows exactly what's the route of the least risk and the safest way to get and land that plane on the ground. Same here. I believe that good experts in combination, doctors with good procurement experts, solid, can land that plane and provide always with a high level of risk, as we are aware. But that's the best answer, I guess, that I can think about, rather than go into recipes or going into what is my personal preference and so on.
Okay. So let me ask just one more question, because we are coming up to the hour and a half mark. So the last question is also building on your experience in working with in some fairly difficult situations, and you working in Haiti currently, Alan. So the question is how to ensure procurement safety and maintaining modern value chain in contexts like the Rohingya refugee context in countries in Bangladesh. And following up on that is what should be, who would be the best type of procurement team? Would it include physicians, economists, representatives, etc.?
So I've worked in a lot of emergency or fragile areas. I've worked through Ebola. I used to live in Ghana, and my countries that I was responsible for include Sierra Leone and Liberia. So we lived through that Ebola crisis as well. And I was speaking to my colleague the other day. He's moved to Tanzania, and I said, well, look, we've been able to now learn so much from our previous experience. All those simple contracts that we wrote by ourselves, and we wrote contracts by ourselves to fit the situation. Look, we now all of a sudden all the World Bank is having them. We had them because we made them up ourselves. So in terms of training and background and being able to respond to, I think it's a little bit like Belcho was saying, trust yourself. If you are already working in that context, like Bangladesh, and having a refugee camp from over the border, and you need a supply, I think you're a very competent specialist. You wouldn't be there unless you were there, and you wouldn't even have come close to it. So trust yourself and use this simple rather than the complex method to come to the right answer, because you know what the answer is. You just want to be able to explain it to others in an organized fashion. So you'll be able to do that if you put the time in. I've been doing that in the last few days with my team. You're asking about the team. We have health specialists, actually WHO or PAHO is part of the team. And so we use them to check out technical quality of our work. We've been able to communicate directly with CDC people who are working from the US embassies, or are good health specialists, and they have reached back to the United States and taken our questions into their emergency team back in the United States. So do reach out to others. We're working with the Ministry of Health, obviously, and they're helping us as much as they can. They have an existing PIU, or project management unit, from an ongoing health project. So they're well trained in health, and we work with them. So it's quite a network that is working on this. Head of our group is an economist, a health economist. So we have everybody in there. Well, let me stop there.
I would just add 2 words for all our good colleagues that are struggling out there. I would say this is an excellent moment to bring in high-level decision makers down to the profession of procurement experts, and somehow make them understand what exactly is going on and what are the difficult circumstances and situations in doing procurement. For example, even direct contracting or whatever other option that we're talking about. And Alan just mentioned it, be transparent. Make sure that you can document everything you're saying, and make sure that your logic of making decisions is one of a lesser risk, and it somehow definitely in circumstances where there is impossible to have competition of bidders of, as Alan said, are there any bidders? Well, I don't think so. I believe that in these critical situations, we really have to trust and have a good connection with the high-level decision makers that to support good efforts and to support the quality and integrity of procurement experts in each one of the countries. Thank you.
Let me just add, Kim, one thing. One of our suppliers who's been in the health business a very long time said, well, you know, that payment which is in progress and you've already sent to the bank, you know, we might be able to send it out without the payment. We'll trust you that the payment will arrive, but I'm going to send it out any day in the next 2 days because the payment might run a couple of days late. So you want to work with people like that.
Excellent, excellent advice. So we know that during this crisis, there's a lot of funds going to medical supply to address the COVID crisis. There's a lot of money being given out, and there's also a lot of people finding that they are now expected to be experts in medical procurement and supply chain management, hence the urgency on why we felt the need to put this webinar together. And we also know that there's a lot of people who need urgent training in this area. So we hope to see you in the ILI online course on medical procurement and supply chain management in July, or see you in person at the ILI course on medical procurement and supply chain management and contract administration in October. I hope this was helpful for everyone, and we wanted to thank everyone for your participation. Thank you very much.
Thank you.
Thank you, everyone.